I'm very lucky to, introduce this very good-looking, but very smart young gentleman. And I looked at his many, talents and all the things he's done in his career and his writings. God, the people he's worked with, the people that he's collaborated with from a technical perspective and how he's contributed to their successes, but in fact how they've also helped him grow as a clinician. And I look at what Christian has brought to us as the Seattle Study Club, whether it's through the National Symposium events that he's participated in the past, or it's perhaps in your study clubs, in webinars, being the ultimate of mentors. You have to look at this person who really is an early adapter. He's brought in technology and tied it in his dental career and has forced us to think out of the box. But so importantly, he's providing us with skills that make us better clinicians. He's lucky he's surrounded himself in his life, in his work life, with his family. Think about how privileged you are to work with your father, your brother, your uncle, and even smarter, now he brings his wife into the business aspect of his career as well. That's the true intelligent young man. My husband knows nothing about that at all. So Christian, you've written so much, you lecture around the world, you inspire many, but I won't take up any more of your time, and I'd welcome you to the stage. Have a lot of fun with us, make us smarter and better clinicians. Thank you very much.
Thank you, Sonia. Wow. Thank you so much. What an honor to be introduced by Sonia. Great honor to be here as well, opening the clinical session. Even bigger honor to be here with Michael, Greg, and the whole Seattle Study Club team. And even bigger honor to be here on stage twice, today for 1 hour and on Saturday, probably one of the most special moments for me in my dental career, sharing the stage, even though it's virtually, with one of my first mentors, John Coyce. So it's really a special event for me. And again, I cannot thank Michael enough for doing and allowing me and giving me this opportunity. Today, during this 1 hour, I want to talk to you about what we call the smile frame. And the smile frame is the core of the whole new way that we are developing of treatment planning and delivering clinical procedures to our patients. Through the smile frame, we can actually make the concept that was beautifully developed by some of our mentors like Coyce of the facially driven treatment planning concept, but bring this to the reality of our daily work in a very simple way through technology. So the smile frame will bring the face to our picture. The smile frame will help us through the treatment planning process. The smile frame will be the key for what we call emotional dentistry, educating and motivating our patient. The smile frame will also be the key to develop all the clinical devices that we need to make this plan become real, from guides and stents and restorations and splints and aligners, everything that we actually need physically to perform dentistry. Through the smile frame, we will make digital dentistry more simple and bring digital dentistry to our daily work. And through the smile frame, we will also do what we call the quality control in between each one of the clinical procedures that we developed. The only way to make smile frame possible is through technology. And that is, for me, probably the most beautiful thing about digital dentistry, not because it makes us look fancier, but because it makes an initial project become very similar to the final result that we deliver at the end of the treatment. So technology for us is helping us basically on these 5 moments. It's allowing us to become a better smile designer, a facially guided smile designer. Technology is helping us to become better treatment planners, a huge challenge to integrate all the specialties in a much easier way by having these 3D softwares in an interdisciplinary platform. Technology is helping us to present cases better, educate better our patients, visualize things better, increase case acceptance. Technology is also helping us, as I mentioned, to create all the devices. Nowadays, there's not one single device in dentistry that cannot be produced with super high quality through CAD/CAM and printing technology. And then control the process, fine-tune the process, change strategies if necessary through the visualization of the process. It's of course a huge paradigm shift in many ways, and I can always look at my career as a dental technician. A few years ago, I was working and my main tasks were to do wax-ups, ceramic build-ups, and take photos. I was living doing that, and I was making my money out of these 3 procedures. And if I look at my work today, these 3 things disappeared. I don't do wax-ups anymore. I don't do ceramic build-ups almost never. And I don't take pictures anymore. Everything was substituted by better ways of doing it, and I'm going to share with you some of them. Also for us was a huge paradigm shift when we started to look of what we try to perform now, modern dentistry, and realize that doing things technically well is not the differential anymore. If we have a good technician doing a beautiful wax-up and a good clinician doing a beautiful prep, the difference between these 2 professionals doing very well technical procedures to what we call the next level is when you actually link the wax-up to the prep. A beautiful prep is only beautiful if it makes sense with the wax-up that was previously done. So for us, the challenge nowadays is not only technically doing something very well, but is to check if that specific procedure is linked to the previous procedure and is going to be followed and controlled by the next procedure. So everything needs to make sense. And this is, again, something that we can only do with technology on a predictable way. Create the links that will make an initial project become real, as precise as possible, as predictable as possible at the end. Minimally invasive dentistry, that is something that everybody's talking about. For us, it's only possible when we become not only great dentists, but we become smile designers, and we take advantage of technology to be able to plan these things in advance. So we can, for example, in this case, move teeth around with ortho and do minimally invasive preps and get to the point where you bring the initial project over the final preps after ortho, and we have exactly the clearance that we need to develop beautiful veneers. Not more, not less. The other huge thing that technology can help is to link the face to the working model. As a technician, probably the biggest challenge that we face every day in the lab. Every time I used to do a diagnostic wax-up, I always felt I was lost in space. I knew exactly the impact of each drop of wax in the patient's face, and that was the main reason why we always had to adjust aesthetically things in the mouth intraorally. This is something that can be reduced drastically nowadays. The challenge of bringing the working model to the face or the face to the working model is the same. It doesn't matter if we go analog or digital. But nowadays, instead of having to deal with these complex devices like face bows that can bring so many errors, everything can be substituted by simple procedures on the computer. We can mount the models digitally. We can link the models to the face. We can link the face and the models to 3D tomography, CBCT images. We can detect with simple intraoral devices the bite, the movements of the jaw to fine-tune the jaw position, vertical dimension, centric relationship. It doesn't matter what functional philosophy you follow, if it's gynecology, functional, or neuromuscular, it doesn't matter. For us in the lab, we can do whatever the dentist wants. The key is to be able to find this comfortable position and to redetermine the vertical dimension for comfort and restorative convenience. we can do that as well in the software. We can then perform a digital wax-up based on these functional information and set up the upper jaw against the face aesthetically, and then bring the lower against the upper, fine-tune the vertical dimension, fine-tune overbite, overjet, and determine how this wax-up should look like. We can also overlap this wax-up into the CBCT image, rotate everything in 3D, and understand the relationship between the wax-up and the bone, the wax-up and the soft tissue, the wax-up and the facial profile. We've been learning a lot from orthodontists and orthodontic surgeons from our team to understand that it's a beautiful idea of utilizing cephalometric knowledge to do diagnostic wax-ups, to do aesthetic wax-ups. Why waste this beautiful know-how that they brought to dentistry in the prosthetic work? So this is what we call the orthognathic wax-up, or the prosthetic orthognathic procedure. Every patient that comes to us that needs a rehabilitation, we will look at them as if they would go through an orthognathic surgery. But instead of doing an orthognathic surgery, we will place the wax-up on that ideal position and then brainstorm how to make the transition between where we are and where we want to be. And this can be easily visualized in the software. So you can see how you can calibrate the CT, the STL file to the CBCT, and allow the technician to develop the wax-up with this new information. So as you see here, what we are doing is actually doing a facially generated sagittal wax-up. We know that in restorative dentistry prosthetics, we always used a lot of the facial frontal view. Nowadays, we combine with the sagittal view to determine the 3D position of the upper teeth. And then beautifully, we can bring the lower against the upper, and we can move things around to get the overbite that we want, the overjet that we want, the vertical dimension that we want, and the inclination of the anterior guidance that we believe is the best for that patient. And once this is done with transparency, we can start looking at the actual position of the teeth and this ideal position to see if that's feasible only restoratively, if that's only feasible with ortho plus restorative, if that's only feasible with orthognathic, ortho, and restorative, and so on, to develop the ideal project for the patient and understand the relationship between the facial of the uppers, guided by the face, and the palatal side, guided by function. So we can really already nowadays substitute analog procedures with these beautiful, realistic digital procedures. No reason, in our opinion, anymore to use conventional face pulse, to use conventional wax-ups, and try to guess in a very unpredictable way the position of the relationship between upper and lower teeth. Another thing that we believe digital is bringing is the predictability, as I mentioned, between an initial project and the final outcome. Whenever you have an initial idea, an initial design, it's a huge challenge to be able to tell the patient that at the end, after ortho, perio, and restorative, maybe implants, we will have a final result that is very similar to this initial result. The only way to bring this to our reality is through digital technology. So nowadays, we can have initial projects, mock-ups, provisionals, and final restorations. It doesn't matter how complex the case is. We can have these three moments very, very, very similar. So the other paradigm shift is that when we talk about anterior aesthetic restorations, we believe that the huge majority of these restorations don't require any more unpredictable steps like waxing, layering, pressing, and casting. We can do everything monolithic. We believe on monolithic dentistry. That's the only way you can make a project repeat itself, by making this project come straight from the digital files. So we nowadays, for 70% of the cases, we do monolithic. It doesn't matter if it's Emax, Empress, lithium disilicate, zirconia, or PMMA, or hybrid materials. We believe in monolithic. That's the way we have to go. So that means that copying nature is not a challenge anymore because the scanners are already copying perfectly the nature. The challenge of modern restorative dentistry is to find the 3D position of the teeth according to the face and the arrangement that you want. And once you set this position, you don't want to change it anymore. Because if you do an incorrect design and the teeth are on the wrong position, you're going to have to trim and fix, and you're going to lose the beautiful surface and morphology that technology is giving to you. So everything comes back to becoming a better smile designer. And that brings us to the smile frame. What is the smile frame? Specific pictures with the specific lines that will guide us through the process of repositioning or positioning the upper jaw in 3D according to the face. It's an aesthetic evaluation. It's a subjective decision. Something that will help us to see better the discrepancies between what the face is asking for and the actual position of teeth and gum of the patient. Then this smile frame will help us to make the decisions of the interdisciplinary treatment plan. We will go through the process of designing these lines through what we call facial dynamic analysis. Everything starts from the video. We don't do any more decisions based on photos. We make decisions based on videos. So everything starts from a video of a patient. Many advantages of doing videos instead of photos. So that's why we don't do photos anymore. We make videos and we take photos out of the video. Every second of a video gives us an average 30 photos. So there's no reason anymore to waste so many hours per year on taking fancy photo protocols of our patients. We can get everything and much more from videos. You can capture from the video the perfect rest position or the perfect smile position. You can record videos from all different angles. So we usually do a very simple protocol with the smartphone on the first appointment. A facial frontal video where we're going to capture from this video the retracted photo and the smile photo. Then we move for the profile, and we're going to do a couple seconds on the profile where we're going to record moments with the stretch smile and rest position, and we're going to make the pictures out of this video. Snapshots, very simple, no need for special softwares. Then we move into the 12 o'clock position, the key position to determine the volumes and the arch position with the face. And we're going to do a snapshot of this video as well after the patient leaves. Then the final occlusal video that will generate an occlusal picture. And these 4 videos will generate the 6 basic photos that we need to frame the smile with the face. Extra videos that we do an interview video from a facial perspective where we're going to capture the emotion and the desires and the expectations of the patient, the expressions and lip dynamics. Then we do a close-up video with phonetics and counting to look into the 180 degrees of the situation of the patient's smile. Then we do a functional video, intraoral retracted, where we're going to capture the movements, the mastigation, anterior guidance, lateral movements, and everything that can be analyzed on the videos. And then the final video, we will do a structural video where we're going to film the occlusal and the lower occlusal surface to have a perspective of what's going on. So it's actually, I'm sorry, not 6, but 8 videos that we do on this first appointment. Everything done with the smartphone. Going back to the smile frame. The smile frame is basically 8 decisions that we need to make. The smile designer needs to look at the video and decide, where do we want the midline to be? Where do we want the smile curve to be? Where do we want the interdental proportion according to this face to be? Where do we want the intra-proportion of the central width length to be? And then the gingival curve to be, and finally the papilla curve. Once we have this initial frame, we can draw where the teeth are and where we envision the teeth should be from this frontal perspective. We move into the 12 o'clock where we see volumes, and we draw the vermilion of the lower lip, and from this perspective we can see if there are asymmetries and how much we want to move out or in. So you can again draw where the teeth are, and you can draw where the teeth should be, and start discussing how you're going to move teeth around. Do you add wax? Do you cut the teeth backwards? How do you want this project to happen? And then finally, the 8th decision from the occlusal perspective, the arch curve will guide us through the process of analyzing the arch form and space distribution. Very important when we are moving teeth around, when we are doing orthodontics, or when we are doing implants. How can we place things on the right position? Now, these drawings can be easily taken forward to any procedure that we do, including overlapping this into softwares. So 5 main reasons why we always do these drawings on a patient that is going to go through a treatment. We're going to use these drawings to brainstorm the case. We're going to use these drawings to share with the specialist and to share with the technician, so everybody's seeing the same thing and commenting with the same image. Beyond the conventional documentation that we share with our specialists, we are sharing this slide, the video and the smile frame. So when people are looking at a panoramic or in a X-ray or looking at the models on the articulator, they also have this slide in front of them when they start to talk and communicate with the other team members. We're going to use these drawings to present the case to the patient. Super powerful too to educate the patients and create motivation. We're going to use these drawings to design the 3D wax-up or the digital wax-up and generate a wax-up that is immediately facially driven. And also, we will move forward into CAD/CAM, guided surgery, digital orthodontics, digital orthodontic planning by overlapping these drawings into 3D, as I'm going to show later. So the first step is to capture the initial dynamics of the patient's face, translate this into a 2D smile frame, overlap the 2D into 3D, either into a conventional wax-up or like we do nowadays, going into 3D digital and making this digital wax-up a perfect copy of the initial project. This project will be printed, and then we will test drive this in the patient's mouth as a motivational mock-up. And when the patient comes back, this is the image that he's going to see before he even makes the final decision if he wants to go through this treatment, yes or no. So this is what we call the initial motivational mock-up, possible because of printing technology. Now, when it comes to the software works in a very simple way. You have 2D and you have 3D. The software will overlap whatever drawing the dentist approved, and then when I'm doing my CAD/CAM wax-up, instead of being lost in space like we see here, we can overlap them and calibrate the wax-up with the drawings that we made guided by the face. So the technician here, the digital technician, will not have to guess. It will only follow in all different perspectives where we want the teeth to be according to this face. Very simple concept. Always from 2D to 3D. Why do we start in 2D instead of jumping directly into 3D? Because 2D is more simple, faster, and inexpensive. Every dentist can start doing the frame tomorrow without having to buy absolutely anything. And we don't have to waste time as dentists into 3D technology. It's much better to invest time seeing more patients. So it's much easier for us to do a simple 2D project knowing that we can control everything that will follow. And the technician in the lab will take care of 3D like we used to do with conventional wax-ups, but now in the digital world. So the beautiful thing here, as I mentioned, is that as soon as the patient approves the treatment, we can take this file and overlap into ortho, perio, implant, CBCT images, and CAD/CAM, and make this project become real. So the idea of an interdisciplinary software platform was always our goal. It doesn't make sense for us to have an orthodontic software or a CAD/CAM software or a guided surgery software. We need an interdisciplinary software. We need a software to help us before we make the decisions of what we're going to do with the patient. Because after we know the patient needs orthodontic, it's very easy to plan the orthodontic. The question is to find out that the best option is orthodontic and not orthodontics, for example. After we know that we need 3 implants, it's very easy to plan the 3 implants. The question is, do we need ortho before implants, yes or no? So what we need is a software where we can throw the patient in. You can throw the patient as a whole in, and the software will help you to go through the process of finding out what is the best sequence of treatment for that specific patient. So what we have on this platform is everything in one. It's a 2D software, it's a smile design software, it's a 3D software, but at the same time, it's a presentation software, it's a guided surgery software, it's an orthodontic, orthognathic software, and a restorative software. Everything in one platform. So it is a treatment planning software. And after we treatment plan, we can use the same software to actually design the devices to perform those clinical steps that we find out were the best for the patient. So we go back to the 2D smile frame. The doctor needs to learn or to buy all these softwares. The doctor needs to go through the learning curve of controlling all this technology. No. Everything the doctor needs is to make the right decision about where he wants these lines to be. Everything else will be followed by the 3D digital technician. There's another huge advantage for us of doing the smile frame, is that we will classify the cases that we do. We realize that every case that we get in the lab can be placed inside one of these groups. And it's very important for us to classify things so we can organize our thoughts and we can serve better the dentists. Either the case is purely restorative, or the case needs crown lengthening plus restorative, or we need ortho plus restorative implants, we need to change the bite, or we need to do orthognathic. What is the key here? As we see, case gets more complex towards the right, but the goal is that we don't want, ideally, to treat tough cases. We only want to treat easy cases. What does that mean? It means that whenever we get a tough case, that means that the teeth and gum are far away from the ideal smile frame. Before we actually restore the case, we want to move things back into the smile frame. So this makes the whole process very simple as a thinking process. If we do the smile frame and we believe that orthodontics will help us to bring this into position, we will plan ortho, move the teeth around, we will do crown lengthen, place the implants, and after everything is healed, what we did, we transformed a type 6, 5, or 4 back into a type 1, and then it's just a matter of prepping and bonding. So we want to prep and bond only easy cases, and everything we need to do prior to that is to transform them back into group 1. So as a technician, we want to help the dentist to visualize that, to make this decision. Is the case an ideal case where you don't need to change tooth position, gingiva position, and neither the bite? This is the easy case, like 6 veneer case, where the bite is going to keep the same bite, and then you move towards more complex cases. We can also evaluate from the smile frame if the case is additive, means to make this guy look better, we're going to add wax, or if the case is subtractive, where we need to reduce certain areas, either moving with ortho or prepping more aggressively. And then the dentist will treatment plan the case to see how he can work around this compromised situation. When we have a pure restorative case, when we do the frame, you see this is an easy additive case. We don't need to change the bite. With this new design, everything was evaluated. We can lengthen teeth, keep the same anterior guidance, and have a safe project. So all we need to do is just to design the frame, place these new shapes inside this new frame, test drive this with the motivational mock-up, and then overlap this into prep guides and into the final restoration. So we get final restorations that are very, very similar or identical to the initial project. We will mill monolithic blocks. Companies are giving us beautiful options with these new blocks. And if the position is right, we don't have to touch the buccal surface. We don't have to polish, we don't have to do texture or to build ceramics on top. Everything comes straight from the block. You mill, you polish, and maybe you stain and glaze, and you have a very controlled final outcome. This is the aesthetics that we are getting from monolithic anterior restoration. It is definitely a reality for many of the cases we are doing. That means scanners, softwares, and milling machines are ready to develop beautiful anterior restorations and give us the opportunity of reproducing nature. We can scan a patient today, and we can rehabilitate this patient in 10 years with the exact same shape, texture, and 3D position, vertical dimension, and occlusion that he had 10 years ago. We can scan a daughter that has a beautiful smile and rehabilitate the mother with the beautiful smile of the daughter. Same shape, same texture, very similar arrangement, everything, following genetics. So why not? It's ready. We are doing. It works. If the patient needs crown lengthening, we're going to design, we're going to detect the need for crown lengthening, we're going to measure this, we're going to make the treatment plan decisions, and we're going to perform this through guides that we will develop digitally. If the patient needs ortho, that means that when we look at the smile frame, we see that ortho can help us to make a type 3 become back a type 1, minimally invasive dentistry, and then restore the case. So we're going to share this design with the orthodontist. We're going to go through the orthodontic procedure. Then we're going to do minimally invasive preps, final veneers, and finish the case. Type 4, detect the need for implants. Maybe ortho, move things around. And if we place the implants ideally, we have to follow a project that was actually designed in 3D. So as you see here on the video, we have the 3D images of the patient. And then, as I mentioned before, we're going to bring the smile frame over the 3D model, diagnostic 3D wax-up, functional analysis, have everything designed, and then this will become a surgical guide, will become a prosthesis, will become abutments, will become whatever we need to go ahead and develop the final outcome of the patient. So as we see here, the software is now overlapping the diagnostic wax-up into the preps and defining the final restorations, a replica, exact copy of the initial design that we developed for the patient. And this will generate all the devices that we need to deliver an immediate loading prosthesis that is identical to the initial project, that we don't need to touch aesthetically in the mouth because it's already facially in harmony with the face. If we need to change the bite for any reason, open the vertical, one dent tissue type of case, we need to find a CR position or whatever philosophy the dentist follows. It doesn't matter. You can deprogram this bite. You can scan this new vertical dimension. The software can overlap them together with the models. We can do what we call the indirect composite prepless restoration. That's the way we rehabilitate many of these cases. We rehabilitate the patient before even touching the teeth of the patient. It doesn't matter what is left underneath. Sometimes they're old restorations, sometimes there's teeth that you need to be extracted. It doesn't matter. We're going to bond them additively over whatever. It's like a bonded night guard. You're going to bond the uppers and the lowers, rehabilitate the patient in one shot. How can we do this? We can design everything digitally. We can create the shapes that we want, all additively prepless, bonded, indirect restorations. We can mill these restorations, and then in one shot you can test drive. We bond and we test drive for 1 week, 1 month, 1 year, 5 years, it doesn't matter. As long as the composite is working well, as long as whatever is underneath is healthy, we can keep moving. And if it's not good underneath, we can test drive until we are comfortable and then start transforming a full mouth complex case into a single unit case if we want. We can treat by quadrants, we can do whatever we want, but the patient is solved. Functionally and aesthetically, the case is solved. We can even go more complex. This patient will go through perio, implant, orthodontic, ortho, and restorative. So we start the same way, the brainstorm, to find out what we need to do with the patient. After we know what we need to do, it's easy to come here and say we did perio, pros, ortho, and orthodontic and restorations. The key factor here was to find out this plan, that this was actually a good idea. So we designed a 2D frame. We share the 2D frame with the team. We discuss pros and cons, biology, function, structure of all the options. And then we present the patient these projects through these slides, through the drawings. So the patient can understand that in her case, we're going to do an upper lip 4 orthodontic. We're going to shift the arch. We're going to segment the right side. We're going to impact the right side, implants on the lowers, and restorations all over. And it's very nice to see how this interdisciplinary software is actually working integrated. So first thing, when you throw the patient into the platform, is that we're going to activate the facially driven smile design part of the software, calibrating 2D with 3D, and designing a smile that we think is pleasant with the face. Whenever we are happy with this, we can then activate the orthodontic part of the software and then bring this wax up through the upper jaw and move the whole jaw with the future final wax up. And check how this shift and how the impaction of the right side will look with this new design. And then we can finish the wax up by placing the wax on the lowers. And then we can start checking the relationship between where we are and where we want to be, and we can always bring the face into the game and check the position with the face before and after, and the wax up before and after in the patient's face. When the orthodontic movement sounds good, we go for the implant part of the software. And now we can bring the wax up into the game because it's related to the upper, that is related to the final position after orthodontic, and then plan the implants with the ideal position and occlusion according to the final position of the uppers. You can measure everything, and you can have this final idea. It's beautiful to do this on the computer because we always say the cheapest moment to make mistakes is on the computer. You can do 20 types of projects in 10 minutes. You can make a mistake, go back and fix, try in a different way before you even present to the patient. And whenever you're comfortable with plan A, B, or C, you can then present to the patient, sell the case, and then the first part of the software will create the devices, models, and restorations. The second part will create surgical models, surgical guides, provisionals, and positioning trays. And the third part of the software will create the surgical models for orthodontic and the splints. So when the doctor goes to the surgery, and this case was done, as we call it, a day hospital case. This is a case of my father, and he does that a lot in Brazil, where he brings the patient full anesthesia in a day hospital, and he does like 5 sessions in one, 6, 7, 8 hours. So sometimes the endodontist comes early in the morning, does the endo, then the perio, crown lengthen, then you do the implants, then you pick up the implants, then you do orthodontic surgery, then you do bonding, then you do whatever you need, and the patient wakes up after 7 hours, and it looks like 5 sessions in one happen. Very, very interesting protocol that can only happen with digital technology. I can understand why they didn't take much pictures. These were the only pictures they gave me of the case, but you can see them picking up the implants, removing extraction, placing the provisionals, lift 4, segmented surgery, placing the splint, biting together, fixing the maxilla, bonding the restorations. And this is a picture after 1 week. We can see the before and the after, and this is a video that they sent me last week of the patient after 3 months with the final outcome of the case. So the 6-case classification, it's a very easy way for us to train all the technicians that are working with us and make everybody see the same thing and think the process together, improve communication. This means that whenever we have a new case, usually we develop 2 projects. One is the ideal project, the other one is an adapted project, mainly when we have subtractive cases. The adapted project will allow us to develop an additive even though it's not ideal, so we can have a motivational markup even when we need to reduce certain areas. So it's very easy to do 2 projects digitally, print 2 models and send 2 models to the dentist. One is the ideal, the other one is adapted to allow us to an additive pre-op motivational markup. So this is usually what happens when the case is not purely additive. What happens is that when a patient comes back, the first thing the doctor will do, and this is the old days when I was doing that with the wax up, so even though this case is subtractive, I was doing an additive wax up to allow us to do a motivational markup for her, sell the case, motivate the patient, and then explain to the patient that she needed 2 years of orthodontics to impact everything, bring things back so we have an ideal case. The more complex the case is, the more motivation we need. So this is what we call the aesthetic potential that we present with the drawings and with the markup. The smile frame also is the key for us for quality control. Very simple. Whenever we do perio or orthodontics, initial design, initial communication, initial planning, clinical procedures are done, new documentation, overlap the drawings, quality control, and see if fine-tuning is necessary. If not, we can move forward to the next step. The same thing with orthodontics. We design initially, plan, sell the case, do orthodontics. When ortho is done, new documentation, overlap the drawings, and fine-tune if more movements need to be done, or if we are ready to remove the braces and move into restorative procedures. So we can see here minimally invasive preps done by Andrea Ricci, case I did with him in Florence, and the final outcome of the case. Orthodontics, very interesting how the digital world is helping us finally to link orthodontics to restorative dentistry. Look how interesting it is. If we draw the lines, the dentist wants to extract the central, place an implant, but before that he wants to take advantage of orthodontics. So what we do, we scan the models, we overlap the 3D image into the 2D smile frame, and we can start playing with movements according to the drawings. It's a facially guided orthodontic movement. We are not guessing. We are not looking only into intraoral images to move teeth. We move teeth also according to the facial integration. And it's very, very easy to do that if we overlap the project, the restorative project, into the orthodontic software. Since it's only one software with all the specialties, you can just jump from restorative 3D wax up into orthodontics, back and forth, and see everything together, even if you want the CBCT tomography in 3D. So you can see the final suggestion of ortho setup. But we can go even further. What I can do now is that I take a patient, I ignore if the patient is going to do ortho, yes or no, and I do a wax up, ignoring also the occlusion and the upper position of the teeth. And I do a blue wax up, only guided by the face. And then we can place transparency to this facially generated wax up and compare to the actual position of the teeth. And then we can start moving the teeth in 3D inside a 3D wax up of the final outcome guided by the face. So you see the white teeth moving, or not moving, I'm sorry, it's a picture, not a video, but you can see that the white central is backwards, and I can move inside blue. Now, I'm not an orthodontist. I don't even know if that is possible. But I can share this image to the orthodontist, and he can say, this is possible, yes or no. We can do that, yes or no. This is going to take 1 year, 6 months, whatever. So we design the case, we communicate, and then if this is possible, we can use the beautiful technology of aligners. The only way, that's why we believe that the modern orthodontists will be specialized in aligners more than anything else. You can do whatever you want with aligners, but the main beautiful thing of aligners is that you can replicate digital projects much more precisely. So if I give you white to blue, you have a set of aligners that you move into white to blue position. So this is what we do nowadays. Initial project, scan the project, overlap 2D, do the facially guided wax up first, check if you can move the teeth into the final position, treatment plan the case, and everything is possible. Just make the aligners to move you from white to blue. Subtractive restorative, also very nice to see how digital can help us through this process. This case, teeth are flaring out. We don't know. We start from the design. So we design the upper jaw according to the face. You can even delete the upper teeth at the first moment, only guided by the face, bring the teeth back and realize that we need to reduce the teeth or move the teeth backwards. So what we do, if the doctor says, I'm not doing ortho, I'm doing purely restorative, so we can now create the guides that will help the dentist to develop this case. First thing we're going to do is we're going to wax this case out. Why? To create a motivational adapted situation. So it's too big, but it's beautiful enough to make a mock-up, take a picture, and show to the patient. Then we're going to move them back to the ideal position. It takes seconds in the digital world. And then we're going to print this model as well to have a reduction guide. And then after that, we can then digitally trim the red teeth. And this is exactly what is happening here. So you see here, as we have the white as ideal, I'm trimming pink. So now I have the ideal project with the pink trimmed. And then I'm going to print this project as well. So every time we have a purely restorative but subtractive case, we're going to print 3 models to the doctor. And we're going to give 3 trays to him to go through the process. So taking this case as an example. Top project, ideal. You see the teeth sticking out. Second project, adapted. It's too big, but beautiful enough for the mock-up. Third project, it's ideal without the blue. We trim the blue. So the first model that we're going to use is the second model, motivation. We put the mock-up in the patient's mouth, film the patient, show to the patient, let him enjoy, approve the case, sell the case. When the patient wants the preps and restorations to be done, we move back into the first model, and everything that is blue becomes a window. It's not a prep guide, it's a reduction guide. We're going to put this tray in the mouth and reduce the blue areas in the mouth until what? Until the third tray goes in. What does that mean? I'm controlling exactly the room for the ideal project, because we don't like to prep teeth. We like to prep mock-ups. We like to prep the ideal mock-up generated by the face. So the third tray only comes in when the first one, the windows are reduced. So when the third is going in, we can do the second mock-up. This is not a motivational mock-up. This is a technical mock-up. We prep through the mock-up. We create the clearance, exact clearance that we want to have the color change that the patient wants in the most minimally invasive possible way. Not only on the buccal of the uppers, but also occlusal of the posteriors. That's how we do. We bond these transitional functional mock-ups, test drive the vertical, and then we prep through the exact clearance that we want. If the patient needs perio, needs crown lengthening, what do? Smile frame, digital wax up, and then we save the project and we do a second project. We trim the gum and we move teeth backwards. So we have the realistic position of the teeth after crown lengthening. So we have two projects sent to the dentist on crown lengthening case. So you can see how we are trimming the gum on the softer in 3D, repositioning the teeth, placing them ideally. And now what we do with these two projects, we print, we do the guides. One guide is overlapping. Why? Motivational mock-up. Second guide is after surgery for the provisional. So you don't have to trim, you don't have to reshape, everything is perfectly in position. So we see at the same time we're planning the surgery. She needs to extract the deciduous canines, place 2 implants, rehabilitate the whole upper arch. So you can see now how the software is overlapping the wax up into the surgical part, CBCT in 3D, placing the implants, planning the implants, designing the guides, designing the abutments, linking the wax up to the abutment profile and to the head of the implant. Everything can be moved since it's one software for all. Everything is placed in the box, several appointments in one shot. So what we do, patient comes in, motivation comes first. Put the mock-up in, show to the patient, super excited, I want to do it. Okay, this is not a realistic position because it's covering the gum, but it's good enough for the patient to see the potential of the procedure. Patient is in, everybody's happy. This is the motivational mock-up. We remove the motivational mock-up. We place the crown lengthening guide. How do we design the guides for crown length for doctors? With this window. It's a window that controls even the zenith position and the shape of the teeth that we design. Even better, it gives you the bone level as well. So you have 3 millimeters above the gum, you have the bone. So if you need to open a flap, if you need to reduce the bone, you can use the same guide for the gum and for the bone. Very simple, very easy. Surgeon can use whatever technique he wants to use. So you can quality control right after. Everything is in place. Now the next step, extraction, fully guided implant placement, final abutments previously done for single implant units. It's totally reality nowadays. Final abutments, fine-tuning the soft tissue, spot etch, immediate provisionalization with the final shape. What is the goal here? Don't need to shape the teeth because they're exactly where they need to be. Even the cervical areas, no trimming. A little bit more complex. Let's blend in restorations over teeth and implants on a bigger case. Facial analysis, smile design, smile frame. 2D becomes 3D in the software. So now we can do the 3D wax up, perfectly guided by the smile frame, guided by the face. When the project is ready, we can evaluate this. The dentist is receiving all these images on his phone before we even print the model. We have approval from each one of the steps, and the dentist can ask for changes. Even the patient can receive these images. STL file is exported, printed model, motivational mock-up in the mouth. Patient likes it, approves the treatment. Doctor preps through the mock-up, impressions. The software will overlap everything, produce restorations identical to the mock-up, identical to the project. Same vertical dimension, same occlusal relationship. Mill the anteriors. Mill the anteriors, monolithic, polish, not even glaze on this case. At the same time, we are planning the surgery with the surgeon. So the software is showing the relationship between the wax up and the ridge and the bone. And what we're going to do, sinus lift in one side, fully guided on the other, abutment design, finishing the restoration design. Everything copied from the initial project. Everything in the box, even the implants, even the surgical guide can come together to the doctor, everything in one. Final abutments, provisionals, surgical guides, motivational mock-up, prep guides, crown lengthening guides, everything. Okay, surgeon is ready, going for the surgery. Fit the first tray, the first guide, fully guided on the left side, partially guided sinus lift on the right side. That means provisional abutments in one side, final abutment on the other. Whenever we have provisionals, we don't send just a provisional. We send a provisional inside a tray that fits in the mouth on a specific position to have the same vertical dimension, same arrangement, same position with the face, same position with the lowers, same position with the rest of the restorations. So we can pick up them in the mouth on that specific position, reducing the adjustments interproximally and occlusally, and having this whole session done in less than 2 hours. So this is the patient after all these procedures, lifting from the dental chair. I'm making a movie. I'm showing him this picture. So he's looking at himself immediately from this picture before he even sees himself in the mirror. A little bit more complex. All-on-4 type of case. How do we plan? The patient comes with an old denture. It's the same for us. It doesn't matter. It's like the old denture is his old teeth. Pictures or videos, pictures from the video, smile frame in 2D. We scan the denture, we scan the ridge, tomography, everything is overlapped in the software, and now we're going to do a wax up over his denture. We can calibrate the positions, we can see that additive in some places, subtractive on the other places, but it's purely facially guided, not taking in consideration the old denture. We can shorten everything. We can play with these images. We can share this with the doctor, even with the patient, to fine-tune this position. It's a perfect copy from nature. These are natural dentition. They look like natural teeth because they are natural teeth. So we scan the nature to improve our library in our softwares. No need for stressing or suffering through creating nature with your own hands if you can copy nature with the scanner. So we can invest more time on things that really matter, like treatment planning, facial integration, smile design, functional solution, interdisciplinary treatment planning, and so on. So the 3D position is done. We can print this, we can mill this as a test drive denture even if we want, to place it in the mouth, motivate the patient, check, and have everything okay, and then we can go back to the software and link now this final design to the CBCT to plan the implants. So everything is overlapped. So now we can relate the wax up to the bone, position the implants, and plan and design surgical guides, bone reduction guides, and the immediate loading prostheses that will be identical to this initial design, since we have the location pins in the whole process. So it's really, really very nice for us to be able to look at these images in 3D and communicate with the surgeon every single detail before we fabricate the final or all the devices that we need. Final case. A little bit more complex because it is a full denture case. Everything is going to be extracted, but we still have teeth. We don't want to lose the references. So what we do? The same exact procedure. Digital documentation. What do we need? A couple of iPhone videos, the 8 videos that we do, CBCT, arch scan and a bite, software brings everything together. What do we do with this documentation? First, we're going to start communicating online. So it doesn't matter if I'm in Japan, my father is in São Paulo, and my brother is in Madrid. We all communicate together better than ever. much better than when we used to work every single day in the same office. Everything is on our phone. All the comments, all the documentation, videos, 3D images, etc. So we are going through these slides that we do for every single patient, discussing the options through a panoramic that is usually a very nice way to have an overview of the case. Option 1, option 2, option 3. Patient and the whole team decided for option 3. So we're going to extract everything and place an immediate denture, upper and lower. Where do we start? 2D design. So I'm going to design the smile frame over the pictures and try to be as precise as possible on the relationship between upper jaw and the face. Whenever I'm done with the 2D project, the 2D smile frame, then a 3D technician will bring this project and calibrate with the 3D model and then do the virtual 3D wax-up. So the upper buccal position against the face. Again, utilizing the concept of the prosthetic orthognathic, this is a typical case that we want to share this image with our orthognathic surgeon and tell him, please pretend this is an orthognathic case. And tell me with your cephalometric analysis and measurements and lines, where would you move the upper jaw to place the central on the ideal position with this face? And they have beautiful ways to do that. So we work also in collaboration with Arnett that is working on this software as well with us. So you can bring this whole knowledge for every single case that you want your technician to develop an upper wax-up. So we have the position, we calibrate this position. We always usually say that orthognathic and orthodontics, they will give us the macro vision of dental-facial relationship. And restorative, perio, us, we will do the microvision, the fine-tuning of this position that we can calibrate according to our convenience, according to how simple we want the treatment to be. So we have our 3D upper wax-up done. We create the occlusion because we have the vertical dimension. We have everything set in this software. So surgical planning, this is going now. Design is ready. Function is ready. Goes to the surgical part. We plan the implants accordingly, and if we believe we need to change the teeth position to facilitate surgery, we can do that. Because we can go back to the design part of the software and move things around. And if we believe the orthodontics can actually help us, and we only figured that out when we were trying to place an implant and it's hitting the apex of a tooth that is adjacent, we go back to the orthodontic part of the software, we move the tooth, go back to the surgical part, reposition the implant to make the final decision, yes, we're going to start with ortho, then place implants, then do the restorations. So implants are planned, everybody's happy with the plan. We can then fabricate the kit that we send to the doctor. What is the kit? We're going to print this initial project to fabricate the motivational mock-up. So the first thing the dentist will do is to motivate the patient, even before talking about treatment plan, even before talking about how much it's going to cost. We do that as a test drive, as the emotional test drive, so the patient can feel confident, can enjoy this new smile. And then the second part of this kit that we're going to send to the doctor is a little presentation to technically explain to the patient what is the treatment behind this design. So beautiful slides that will show in 3D everything that needs to be done to make this project happen. So first motivation, second education. So it's design, plan, the patient accepted, we can move forward towards the surgery. So now my brother is flying in, he's the surgeon, so he's coming, surgeon, he's from Madrid, he flies in there, he meets the patient, the magic box is there, everything is there. So what he does, when the patient has teeth, we have two sets of guides. First guide, horizontal pins, and that's all we do with this guide. Remove this guide, we're not going to use this guide anymore. Now, we can move forward for full extraction, upper and lower full extraction. We don't want to lose the relationship. Remember, everything to make sense needs to be controlled. So what we do, even if we're going to reduce the bone, if we see in 3D that is needed, we can fabricate a reduction guide that stays on the exact position with the same 3 pins. So we see the 3 pins now also on the lowers, and then we can place the implants fully guided or partially guided. I believe that for full arches, it doesn't make sense to do fully guided, but this is up to the surgeon. Because fully guided for me only makes sense at the moment that technology is allowing us to mill a frame, the definitive frame, beforehand. Then makes sense. And this is not there yet. So it's just extra stress that doesn't make sense. Initial drilling, remove, conventional drilling, finish the position. So it's partially guided, intermediate abutments, and then we can come back with the prosthesis. Now the trick here is that instead of sending a provisional like this, what we're going to do to avoid being lost in space and lose the vertical and lose the facial integration, what we're going to do is to fabricate a provisional based on the same vertical, same design like this. So the provisionals, they come with strategic pins to place them in position so we can capture that same position we planned on the software. So we see the whole sequence here, very simple, very controlled. Softwares can do everything very, very easy. It's just a matter of the surgeon creating the strategy with the computer technician to design these devices. And it's just a couple seconds looking at these images and we can make this strategy happen. So now we can pick the implants, unscrew, finish outside the mouth. These immediate prostheses, we usually use PMMA blocks just for a short period before we go for final restorations. And then we can capture also the lower, and that's the beautiful part. We capture the lower, we ask the patient to bite, and we have an occlusion even before adjusting that is very close to ideal. So then we can fine-tune occlusion, make everything the way it needs to be done. Now the second advantage here, we can even put some pink if we want, but the second advantage is the facial integration. Whenever you ask the patient to stand up right after the surgery, so remember, this is a long procedure. It's a whole day procedure that we did everything in one shot. The patient is standing up, and you have to believe me on this. We didn't adjust the provisional aesthetically. So this is the way it came from the capturing of the pins from the initial design that we developed. We can even do quality control, and things are pretty much into position. What is the beautiful thing here? Whenever the implants are integrated, we want to move to a next prosthesis. The files are there. We can scan the implants, we can overlap the images, and we can develop bars, monolithic, full zirconia, dentures, whatever type of material, single crowns on a sub framework with pink, whatever we want can be designed with the same exact shape and position of this prosthesis. So we see our final patient over here. This is what we are really believing on and we are really using. Completely digital design, philosophy of facially guided treatment into the digital world, functionally planned also in the digital world, and of course keeping the biological principles of dentistry. So we see the whole workflow, and for me it's very, very cool to see that everything started from an iPhone video. And the only thing that I did on the case was the 2D smile frame. This is my brother, the surgeon, the one who did the whole clinical part of this case. And to end the final slide, just one quick question, is that are we ready for this? Because technology is ready. It's not the future. This is not the future. This is not something that is more expensive. It's actually less expensive. And it's ready for us to take advantage of it. Thank you very much. Thank you.
So again, I'd like to thank Christian. So first of all, what I'm going to think about on Monday when I'm back at work next week is I'm putting down my camera, I'm picking up my smartphone a lot more. I know we've all embraced our computers. They're a big part of our lives, but obviously this is even more impacting. And I think the whole concept of treatment plan before we treat, how important is that? We've all learned through making errors along the way. Your failure, Christian, is that you haven't eliminated us yet from the whole process.
No, never.
It's just not our computers yet, but you can develop that robot that takes these hands out of it that still makes those little mistakes.
This is not eliminating anybody, neither technicians or doctors or specialists. It's changing our focus on it.
Absolutely, but you've motivated
Challenges are still
you've
there.
motivated those patients, and now it's a matter of we're inspired, and now we have to motivate our teams to really embrace this whole
one of the main challenges.
change. Yeah, exactly. So thank you very much, Christian.
Thank you.
Where do you start, right, when you go back to work? So Christian, you're going to be busy with a few emails, I'm sure, along the way. So thank you again.
That concludes this program. This material was recorded and produced by Mobile Tape Company Incorporated of Valencia, California. More information about other available media may be obtained by calling 1-800-369-5718 or on our website, mobiletape.com.